Dr. Pankaj Bhansali, we listened to him before lunch. He is pediatric nephrologist at Sambhajinagar. Dr. Puneet Chajed, he is KEM alumnus and now working at Jupiter Hospital for with his expertise in pediatric nephrology. She is again a KEM alumnus, so we take pride in having our two alumnus sitting among us.
I am a KEM alumnus.
Yes, sir. Yes, sir.
Good afternoon, everyone. So Vipul has given us a difficult task to keep you all awake post-lunch. So we'll try our best. So we'll have a discussion about chronic peritoneal dialysis in children and focusing on points which will be different as compared to adults. So we have a 4-year-old girl was diagnosed as primary steroid-resistant nephrotic syndrome at 2.5 years of age, at which time she had a normal GFR. Biopsy revealed that she had FSGS, but she didn't respond to tacrolimus. And now at 4 years, she presented with oliguria, edema, and seizures, and was found to have creatinine of 8 milligram per deciliter and hypertension. She was initiated on hemodialysis through right IJV access, and parents, after discussion, opted for chronic PD as a bridge to transplantation. So we have actually covered the indications for initiating kidney replacement therapy in children. So I would request Dr. McManus to just briefly kind of go through the indications once again for the benefit and emphasizing.
So can we go on the first slide? Thanks. On the first India. I'll take a little bit of time with all the adult colleagues. So you can see this child is a malignant FSGS, gone from 2.5 years of age to 4 years, within 1.5 year progress. And always in pediatrics, you are worried about growth, nutrition. So that's the primary thing, and she has presented with severe seizures, so not neonatal, severe hypertensive encephalopathy, the blood pressures are very high. So the most important indication I would say is, and there is already eGFR would roughly be around less than 5 to 10 mils per minute per 1.73 meters square. So inability to maintain volume status and severe hypertension, absolutely no residual renal function, because I'm sure the child has very, very poor urine output, which is though not mentioned. So the most important indications would be for volume status, hypertension, also for various uremic complications. We start with the head, uremic encephalopathy, uremic anorexia. Most important, response to nutrition. This child should have been on gastrostomy, we'll cover that later, but if the child is failing to thrive, which I'm sure this child is, though the height and weight are not mentioned, but there is again oliguria, edema, so you'll be overestimating the edema weight and feel that the child is growing. So if a child is not growing, obviously the child has to be on PD, and I think PD is the best option because it also gives you calories through your dextrose which is present. So these are a few indications, and I hope I have not missed anything. Other thing would be other system involvements and resistant indications. And we have intractable pruritus, which is an indication, and serositis. And I think I have covered other things, and no response to growth hormone and other medical treatments. We don't use growth hormone right, left and center in pediatrics, but these are the indications from the KDIGO practice guidelines.
So as sir correctly pointed out, in contrast to adults, one thing which we need to focus on in children who have CKD is their growth. So if the growth is not responding to the optimized nutrition and medical management, they should be considered for kidney replacement therapy. And all of the symptoms usually occurs at GFR of 5 to 10 mLs per minute per 1.73 meters square. And this is roughly, sir, if you can just say, what is the indication to start PD, which will be almost equal as the indications to start any kidney replacement therapy?
So the ISPD guidelines mention eGFR less than 10 mils per minute, but I think our criteria are not solely on the eGFR value, it's the entire clinical status of the picture and more important growth. And again, CAPD has been quoted as the most ideal mode of dialysis in children, especially for MIC, middle income and lower middle income countries.
I request Dr. Pankaj Bhansali, of course he has covered this point also, but to just summarize the advantages, why are we pediatric nephrologists so passionate about CAPD over hemodialysis?
For hemodialysis, we have a lot of problems starting from access site, availability of equipments, availability of expertise. Sorry. Then even the residual function is better preserved when child is on peritoneal dialysis. And as compared to there, in peritoneal dialysis, it is definitely preferred for younger kids, particularly less than 5 years of age, where we don't need any extracorporeal circuit, so no risk of hypovolemia, no risk of IV access, no need of waiting for longer duration or AV fistula failure. There is a better freedom for the kid, like child can attend schools betterly, there will be less miss of his school and play activity. Only thing we need to adjust the PD cycles according to his his daily routine, with his schooling and activity also given appropriate priority. The risk of hemodynamic instability is very minimal with PD. So PD will be a definitely preferred mode in pediatric population.
Yes, and we know that hemodialysis cannot be done daily and it's an intermittent process. And CAPD being a continuous process has a better advantage in terms of growth and survival also. And a study has shown that the preservation of residual renal function is better preserved when the child is on chronic peritoneal dialysis as compared to maintenance hemodialysis. So, sir, can you just say in which condition we cannot choose peritoneal dialysis as a modality?
Before medical condition, I think social condition is motivation of the parents. If parents are not motivated well, then I think PD is out of our options also. But medically, any problem with diaphragmatic membrane, any problem with peritoneal membrane or abdominal wall dehiscence in the form of gastrochesis, omphalocele, diaphragmatic hernia, these are absolute contraindication for peritoneal dialysis, because the fluid will leak either into outside the body or into the pleural space, and that will compromise our role of PD itself. If peritoneal membrane is extensively scarred, like if there is a significant history of peritonitis in the past or any GI-related surgeries which has caused peritonitis, where membrane is likely to get hampered, remains another relative contraindication. And there are some other relative contraindications like any stomies. If there is a colonostomy, ileostomy, then it is also a relative contraindication, but it is not absolute. If we don't have option, we can give a trial, and if it does not work, we can resort to other option.
Thank you, sir. So I would just like to highlight that most of the children have CACUT in whom they progress to CKD, and they can have associated comorbidity in the form of either having imperforate NS for that, or CACUT in the form of reflex nephropathy. So they can have ileostomy and ureterostomy. And the relative contraindication is in terms of maintaining the hygiene, because otherwise if we initiate PD, the chances of peritonitis might increase in the children. I would like to ask Dr. Puneet that what are the different types of CAPD catheter that are available, and how do we go about choosing them?
So when coming to selecting a PD catheter, there are two things that we take into consideration: the catheter considerations and the patient considerations. So patient, the size of the patient, whether this is a neonate, whether this is a child or an adolescent, and the weight of the patient. A rough guide is to the length of the catheter that needs to be inside the abdomen is distance from the pubic symphysis to the umbilicus of the child. And this is like generally translates into 37 centimeters in less than 10 kg kids, and around 42 in more than 10 kg kids. Now coming to the catheter characteristics, as we all know, there are single cuff, double cuff, straight and swan neck type of insertion, and whether the intra-abdominal portion is straight and coiled. So in pediatrics, it's always preferred to have a coiled catheter and a swan neck double cuff catheter that has shown to decrease the risk of peritonitis and the duration to the first episode of peritonitis after starting PD.
Yeah, so the swan neck basically helps to kind of prevent the migration of the catheter, which is one of the common complications which we come across in children. And as Dr. Puneet pointed out, coil catheter, if available, should be preferred, because as the child grows, it really helps. Otherwise, the straight catheter, it might somehow not drain the fluid properly in case of straight intra-abdominal section. So, Dr. Puneet, what is the ideal exit site which should be chosen for PD catheter placement?
So as discussed previously, there are various other openings on the abdomen which the child might be having, like a ureterostomy or a ileostomy or a cecostomy. So the exit site has to be away from the nappy line and away from all these stomas. The ideal direction of the site is lateral and downwards. The catheter should be placed in such a way that the deep cuff is in the rectus sheath, and the superficial cuff is just under the subcutaneous tissue, and you don't have enough torque on the catheter, and the exit side, as I said, should be directed laterally and downwards.
I would also add that many of these children, we advise them to undergo gastrostomy, which will be on the left side. So the preferred, when we consult with the surgeon, we should tell them that preferably they should put the exit site on the right side, that will be lateral and downward. So what are the other precautions? I would like to, just a minute, I just missed this. Yeah. What are the other precautions which should be taken before or while PD catheter insertion? I would like to ask Dr. Madhura to take this question.
Good afternoon. So preferably all these measures are done. The first and most important is that we want to avoid peritonitis or any risk of infection. So prior to the catheter insertion, we need to give antibiotic. So first or second generation antibiotic like cefazolin is preferred. Then again, to prevent the migration of catheter or the risk of catheter getting blocked, laxatives should be given again pre-op, and to ensure that the child is not constipated. Third is omentectomy is preferred to prevent the risk of omental wrap and further complications and risk of catheter block. And even fibrin glue can be used to avoid the leak of peritoneal fluid. And staples and sutures should be avoided at exit site, again to prevent the risk of peritonitis.
So here we can see an image where the catheter is seen to be blocked by the omental wrap. So it is very important for the surgeon to do omentectomy, because the children have a larger surface area of the omentum as compared to adults, so they are more prone to cause obstruction of these catheters. And as Dr. Madhura pointed out, be sure that the child has received laxatives before he goes to the operation theatre. That is a very important measure to be taken to prevent peritonitis, in fact in the post-operative period as well. And Dr. Madhura, what are the precautions which should be taken once the catheter has been inserted?
So it is important that you don't touch the catheter and don't touch the exit site also for 1 week, so that there is no movement of the catheter within the tunnel. Then you should avoid any occlusive dressings. And after 1 week, we should start cleaning the exit site, and we should use normal saline or chlorhexidine. There is strict no for povidone, iodine or hydrogen peroxide, because both of them are irritant to the skin, and that can cause delay in healing of the exit site. So it should be avoided.
Yeah, thank you, Dr. Madhura. So very important, again summarizing that not touching the catheter for at least a week, because we want that fibrosis to happen on the superficial cuff. That is the way we will prevent the extrusion of cuff, because these children maximum of these children are poor in nutrition, and if the proper fibrosis around the cuff has not occurred, there is very higher chance of cuff catheter getting extruded. I would like to ask Dr. Matnani about opinion about gastrostomy tube placement with respect to PD catheter insertion, and do we advise it to all or do we advise it to certain population only?
Okay, so interesting question, very controversial as well, in India particularly. Having worked abroad, we used to just do gastrostomy and CAPD catheter insertion together, or gastrostomy used to be done before. Let me just switch gears and take you back to omentectomy. I will just differ here, because we do, since last 20 years, I have been doing omentopexis now rather than omentectomy, and I'll tell you why we do that. Because omentum is a very good immune organ and it's needed for children, and all the more for CKD, ASRD, because they are immunocompromised children. So what our surgeons do, they take a subcostal incision here and they get out the entire omentum and roll it up rather than removing it, put it back in the tummy, suture it, and then it will never cause a problem. Coming back to this, if you want to put I think KEM has a good track record of gastrostomies. You all do it quite often.
Not quite often, but we do it.
But honestly, I must agree here, I had done a single patient, but it was a disaster. Well, let me not go there. So, but the thing is, it is a package. As she will tell you also, it's a package. You have to tell the parents, I'll explain you why. Because CKD patients have altered taste, so they are not able to eat. They are anorectic all the time, dysgeusia, that's what we say. Along with that, there is a lot of gastritis. There are so many medications to be given, the child will not take it. So that will cause additional gastritis. And on top of that, they are just not feeding well. So to cover all these aspects, best is to put a gastrostomy in situ first, and followed by that a CAPD. doesn't happen in India, this ideal setting. So best is do it together, but never do the gastrostomy after PD, because it can cause a big problem for peritonitis, because it's more handling of the abdomen again. So best is to consider counseling the parents about both. And in India, the limitation is about the feeds which are the gastrostomy feeds. Usually abroad we used to give overnight feeds, and they're very expensive. The patients have to pay from their pocket. But in India, I don't know the availability. Is it there or not really there?
So initially the gastric people, they put a police catheter, and then later they change it to Mickey butter.
Yeah, that's fine. I'm asking about the solutions which are there for gastrostomy, formulas which are for feeds, gastrostomy
So
feeds.
our dietitian kind of customize it so that it can be given
So
through
the ready-made
gastrostomy.
formulas are not available, but it's a challenging task for us as pediatric nephrologists. But obviously it is an ideal thing, and it's very important to use a prophylactic antifungal, as mentioned there, fluconazole. So these are a few thoughts on gastrostomy. Always very important, needed, but a little bit impractical in the settings of India.
Yeah, so as sir correctly said, that always when you are counseling about CAPD, counsel them that the nutrition is very important for the success of PD as well. As I was alluding to earlier, that the nutrition is very responsible, as we have seen patients just coming up with extrusion of cough, and then that kind of precipitating the infection. And in fact, in our pediatric nephrology conference, many pediatric nephrologists have shared their experience with gastrostomy, that many children, they go to transplant and the medicines can be given through the gastrostomy tube, so they don't kind of have a fear for the medicine. And in fact, some even mention the experience that the children themselves then say that don't remove my gastrostomy because I don't want to take the medicines orally. Yes.
Me or for
Gastrostomy. Yeah, it is mentioned in the ISPD guidelines that if you are planning a gastrostomy, use a prophylactic antifungal before the placement.
and not for CAPD.
No, CAPD only first or third generation cephalosporin. I would like to ask Dr. Pankaj, how do we, once now the catheter has been placed and a week has gone, and how do we go ahead in training the caretakers for performing the peritoneal dialysis?
So after insertion of the catheter, another important task which will ensure that our procedure had been a success is training. And training will be of two things. First, let the parents understand what are the all equipments, what are the parts of this catheter, and when shall they intervene. Now here, first, at least two caretakers should be involved. If one is not available, another person also should be ready how to handle this CAPD in and out procedure. They should be, preferably, I prefer training them in hospital. Ensure that they have done in front of our eyes, they have done the way we want, and at the same time they have keep well record of everything. So not only the procedure, even keeping record is also mandatory. So if everything should be done in front of us, and then we can ask them to go home. And in this, the most important thing is hygiene. Cleaning of hand before procedure, using all aseptic precautions, because the most important risk factor for CAPD is infection. And second will be mechanical issues because of catheter. So if infection is taken care well by parents, the risk of this procedure lasting for a long time will be a very good sign. And they should be also aware of the emergency signs, emergency symptoms when they shall immediately report. And these are mainly again for peritonitis. If fluid is turbid, if there is a pain during inflow, outflow, or any abnormal feature, they should be aware that how shall initially be tackled and report immediately. So this training must be done of parents before they leave the hospital premise.
Yeah, so this is one of the booklet which is provided by the Baxter technician when they train the parents. So ideal would be to have a PD nurse, or if we don't have, we have Baxter technician who come and train the caretakers about it. One of the practical thing which we have come across is if you have a slightly older child, like 10 or 11 years old, involve that child also in the process, because we have seen that they will point out if certain step is missed during the process, that you have not done this, please do this. So that is very important. And another important, please ask them to go through this booklet, because this is a very nicely prepared booklet, and it has all the information in all the 3 languages, whichever the, at least in Maharashtra, which the caretakers are fluent in. And third very practical point, as Dr. Pankaj also pointed out, training within the hospital and review that they are able to keep the records. One of the personal experience was we explained everything with discharge, and on first follow-up after 3 days, we saw the diary and it was just haywire, and we asked the mother and she said she can't calculate. So she didn't know how to kind of calculate if the in is so much and out is so much. So we had to involve another caretaker who to take care of this. So this is just one of the things which you have to see that everything is done before you discharge the patient. And this is just, I think everyone knows this, this is just similar to what we do in adults, the apparatus. And Dr. Puneet, how do we start the PD and what are the components of the prescription now that we are starting with the training of the caretakers?
So theoretically you can use the PD catheter immediately after insertion, the next day after insertion, but everyone wants to wait for a couple of weeks before we actually break in and to start the actual PD. This is because the catheter should heal and be very sitting firm in the place. So the prescription generally is inclusive of the dwell volume, the dwell time, the number of exchanges and the type of fluid. These are the major heads under which the prescription for PD is written. And till the time we are waiting for the tract to mature and the catheter be secured in place, a weekly flush of the catheter is what is advised, so that you don't have fibrin plugs there. Another important thing is securing the PD catheter in place after it's in situ. So this is some indigenous way of keeping the catheters in place. These are the belts that our kids wear to school. One more important point is the school authorities need to be made aware that this kid has something like this here, so that the some kind of physical activities which is restricted might be, the teachers and the coordinator should be aware of it. Now, initiating chronic PD, if early break-in is required for conditions like if you cannot wait for dialysis, then ensure that there is no leak at the exit side. So ideally, to avoid this kind of situation, it's better that PD insertion is done as a planned procedure and not as an emergency way. You can keep the child on hemodialysis and then insert the PD catheter and wait for the break-in period to limit these leaks. The PD should always be done in a supine position so as to recruit the maximum area of the peritoneal membrane. And you initially start with low fill volumes of about 200 to 300 mils per meter square and gradually increase as tolerated. Hourly cycles to be done at least for the first 1 to 2 days. And everybody knows this is the flush before fill. You just try to flush the catheter with the patient end being clamped. You flush the catheter in the circuit once, so that you're getting rid of all the contamination whatever might happen during the handling, and also remove any air bubbles. We'll come to it later, because if you have air bubble, that might be a cause of pain. And I don't think I need to go into this in detail. This is just the gradual increase in dwell volume that we follow. And if you are starting after 2 weeks, this is what is advised. The target being 600 to 800 mils per meter square in less than 2 years old, and more than 2 years old, 1100 to 1200 ml per meter square should be the dwell volume to the target.
Thank you, Dr. Puneet. So as we need to remember the targeted or the escalated, till what volume should we escalate, because that is the volume in which the peritoneal membrane will be maximally recruited and will give you maximum efficacy. So Dr. Madhura, how do we go about determining the dwell time? Once we have come up to a particular dwell volume, then how do we go about determining the dwell time?
So for dwell time, it is important to find out how much ultrafiltrate we are getting from the patient and how much is the clearance. So that depends. So there are two things. One is the short exchange. In short exchange, what will happen is that there will be increase in the number of cycles as well, and so it will be beneficial in terms of getting a good ultrafiltrate. At the same time, the solute clearance, that is of the small size molecules like urea and potassium, will be beneficial. In long exchanges, especially important for middle molecule clearance like like phosphate. And but what happens is that because of a long time of the fluid being in the peritoneum, the loss of gradient will occur. That is, the osmotic gradient will decrease over time. So we won't get a proper ultrafiltrate. But at the same time, it is necessary to know what is the transporter status. So the next important point to consider is what is the transporter status of the child. So in general, what we observe in children is that in infants and younger children, they usually are high transporters. So in high transporters, it is that the transfer or the transfer of the molecules is occurring in a faster way. So they usually benefit from a shorter dwell time and increase in the number of cycles to get an adequate ultrafiltrate. Whereas in older children and adults, they are low transporters. So the transport of solutes will occur slowly. So they benefit from a longer dwell cycle, and they will also benefit more in terms of increasing the dwell volume. Now, theoretically, there is the peritoneum equilibrium test which is done, but nowadays it is not followed, because if we keep a weekly follow-up and a strict follow-up of the child and observe his ultrafiltrate and clearance, we can get a better idea, and then we can change the cycles accordingly. And again, third important point is residual renal function. So if the urine output is good, then the ultrafiltrate needed is obviously less. So then we can titrate the cycles accordingly.
So as Dr. Madhura said, the PET, there are actually many controversies around it. Many centers, they do it regularly, and it is to be done 1 month after the PD started, and then every time if the child has PET. Hello. Yeah. So I was mentioning there is controversy around PET, that how frequently it should be done and whether it's really relevant. In personal experience, we have seen that somehow the results of the PET does not match to the clinical results which we see from the PD diary. And our colleagues also say that PET is not practically recommended, at least in nowadays, not done in children. So we are not going to discuss about it. So I would like to ask Dr. Matnani, what are the different types of PD fluid which are available?
So I think it's all of us very well know that the the concentration of glucose, that's a small molecule dextrose, is important because it helps us in the colloid osmosis. And available from Baxter and Fresenius, abroad US, UK, I think UK, 1.36, 227, 386. India we have 1.5, 2.5 and 4.25. Sorry. So yeah, now it's audible. You can see we use Baxter. Baxter is universally available in India. Dianyl and Physionyl, the most important difference between the two, the name itself will tell you. Dianyl is usually consisting of lactate, which is acidic pH, and therefore the pH being low, on the long term it is not good for the peritoneum. And Physionyl, as the name suggests, it's more physiological. The pH is more towards the normal body pH, and it contains little bit of bicarbonate, so which is much more physiological, and the low glucose degradation products are a little bit less in Physionyl. So for a long-term health of the peritoneal membrane, it's good. But again, the limiting factor, it's a bit more expensive. Fresenius, we have a few bags. I have a little bit of experience again from abroad. It's available from Balance. The solution is called Balance. It has 2 compartments. There are 2 bags together. They're attached, and there's a beautiful mechanism. You start rolling from the edge, and the seam breaks, and then both the 2 fluids mix together inside, and then so that it comes into the catheter tubing, you keep rolling it, and then the other lower seam breaks. So it's a beautiful way to learn if someone wants to learn how to do. And the other thing is, these 2 solutions are available. Nutrienil, the name suggests it's more for nutrition. Again, remember, this is only a predominantly amino acid containing fluid. It has no glucose. So sometimes people feel, oh, it is used for dialysis. No, it's only for supplementing amino acids to build the protein in the body for nutrition. And a very fantastic molecule. So coming back to Nutrienil, we use 1 bag of Nutrienil if affordable, along with the other dialysate Physionyl. But this is only exclusively for nutrition, not for dialysis. And icodextrin is a boon molecule for us. It is usually we used to do it again here also. We do it for very small babies who usually are high transporters, and over a period of time, they initially 1 or 2 hour cycles, they produce good ultrafiltration, but over a period of time they become low transporter. And I'm speaking about 20 years ago, my GOS training, where we used to do PET test routinely. I still do a little bit of PET, but again, as Jyoti said, that it's 2 variations, like some people believe, some people don't believe. So it's good to have 1 PET test after 4 to 6 weeks just to know. But otherwise also from your PD prescription, once you've started doing PD, if you know that the ultrafiltrations are poor, they are better on long-term dwells, then it is obviously a low transporter status. So in some patients, icodextrin is used. It's a molecule, it's a glucose polymer. It creates a sustained colloid osmotic gradient, and the osmotic gradient doesn't dissipate. So it is a boon for patients who have very low UFs, and it's a standard 8 to 16 hour, we usually give it overnight icodextrin fills. The only disadvantage in smaller babies is they can have a sodium sieving effect. So they can lose a lot of salt in the PD fluid, and therefore we need to give them extra salt supplements. It's exclusively for very small babies, but a boon for low transporter status and for patients who don't have a good UF on the standard cycle. So this is a very good molecule that way.
Thank you, sir. So, am I audible?
Yes, yes.
Yeah. So, the physionyl has, the mention here has a pH which is 7.4. So, that's a physiological pH. That's why it's called physionyl. But unfortunately, it's still not available in India. But once it's made available, physionyl will be a better drug, better bag to use as compared to Dialyl, which has a pH of around 5.5 and is responsible for the changes in the peritoneal membrane, which eventually occurs over a period of time when child is on a prolonged period of peritoneal dialysis. So Dr. Pankaj, what are the different modalities which are available in children which we can use for chronic PD?
The most common or very frequently used is manual, where parents are taking care of the cycle. So we can titrate the cycle according to child's need. We can have a long dwell in school going time, and then we can have short dwells in the night. But again, it's consuming a lot of manpower, because mother or father will be stuck with the child to manipulate everything. And as I said, being a smaller kid, once bag is attached, most of our kids are from unaffording family. We cannot detach the bag and waste that. So till that bag is over, child will be attached to that bag. So it becomes a little cumbersome for the kid, and we need to manage that bag according to child's schedule. So that is manual bag, because we have only 2 liter bags. Then we have automated bags, where a 5 liter bag can be used, and it is, we have neonatal or child cartridge, so machine will guide how much fluid is going in. This is definitely comfortable and can be used particularly for nighttime dialysis. Again, 5 liter bag for a daytime will last for entire day, so we can stick the child to the machine for entire day. It is mainly used for a nighttime dialysis. So we have, this is the machine showing it. So different cartridges, both neonatal and pediatric cartridges can be used according to his weight, according to the weight of the child. Okay.
Dr. Pankaj, would you like to just give summarize the fill mode and standard mode which are available in the APD machine which we have?
So the standard mode, which generally which can be managed with adult cassette, where at one time 1 liter can be infiltrated. But if we need a smaller fill volume, that is low fill, in that we have a pediatric mode, pediatric cassette available. Pediatric cassette has a very accuracy which starts from almost 1 ml increment, particularly if it is less than 100 ml, and if it is more than 100 ml, increment is in the tune of almost 10 ml. So accurately we can guide how much volume has to be instilled inside, and at the same time the recirculated volume is also minimal in low fill volume. So for a smaller kid, definitely that has an added advantage over that.
And can you just cover what are the different therapies in the chronic peritoneal dialysis which we use?
Okay, I think everyone of us might be knowing it. So manual is in our hand, so we decide schedule. Generally, we give first break at morning hours 7 to 8 a.m. so that child can go to the school, and after coming back can be reattached with a fresh bag. Then there is a nocturnal automated PD, where child is attached to a PD machine, and throughout the night, like once child goes to sleep somewhere around 9 or 10 p.m., till child awakes, machine will deliver all the required cycles. In this, we can add one more cycle in the morning also. So that is APD with a short day dwell. Then there is a tidal PD where we don't drain abdomen completely. We keep some amount of PD fluid inside, and the rest fluid will be in and out according on automated PD machine. Then CCPD where night PD is associated with one as a long dwell throughout day. So last cycle is instilled in the peritoneal cavity, child is detached from the machine, child is free throughout the day and again gets attached to the machine in the night. So there is added advantage of one full day dwell. Then we have APD with 2 day dwells where along with machine we may need to use a manual PD cycle once also. So these are the different modes. Frankly, we need to cater according to the peritoneal membrane of the child and his daily routine, because we cannot compromise on his childhood also, his schooling and play activity also.
So in an ideal situation, it is said that to begin with, if you have the access and the parents are willing, start off with the nocturnal automated peritoneal dialysis, so that the child remains free in the night, and the nighttime cycles take care of not only the clearance but the ultrafiltration. And of course, tidal PD is preferred in children who have pain during outflow of the PD fluid. So, Dr. Puneet, now once the child has been initiated on chronic peritoneal dialysis, how do we monitor these children on the follow-up?
So needless to say, you check the child for his weight, his anthropometric measures, blood pressures, fluid hydration status, and most important, how is the record keeping of the cycles and what the logs are looking like. Does your physical exam findings corroborate with the PD logs? Again, parents are taught to have blood pressure monitoring. Just double check if the blood pressure monitoring at home and in the clinic is the same or different. Then there are investigations that we generally advise for as a routine monitoring monthly basis. You check for the CBCs, the kidney functions, electrolytes. Quarterly check for the minerals, calcium, phosphorus, PTH, vitamin D. Nutritional assessment, it should be an ongoing thing, but a good review should be taken quarterly just to consolidate your efforts. 6 monthly, there needs to be a transfer set change, and annual ABPM and anti-Hep B titers. Needless to say, the pink star at the right bottom is like there's a continuous reiteration for the need of kidney transplantation and motivation for parents to become living donors or someone from the family. The monitoring, Baxter has come up with a new machine, a Home Choice Pro machine, which is not yet available in India, but available abroad. It has a share source platform, which along with the machine, they give you a modem-like thing, a router, and the data is sent to a cloud storage over a secure network. And the share source platform, you can access it from anywhere. You can sit in a house looking at what, suppose if you have a patient coming to your OPD tomorrow, and you can very well see the logs beforehand and decide what needs to be done and how the dialysis is happening and all these things. But as I said, it's not yet available in India.
Thank you, Dr. Puneet. So again, I would like to stress on 2-3 things on this while we are on this slide. So ensuring that the child is having daily bowel movements is a very important aspect, which we keep because the parents won't come forward with this complaint. We have to keep on cross-checking with them, is the child moving his or her bowel daily? And if there is even minuscule of doubt, just keep them on laxative for some time. That will be the best way, because having constipation is one of the reasons which predisposes them not only to peritonitis but also to the migration of the catheter. So that is one point which I need to emphasize, and I have put it, this is kind of implied that PD is a bridge to transplantation, so why do we need to continuously reiterate? But in India, once the child is on PD, they just forget about transplantation, and it's very difficult to then convince them to kind of go to kidney transplantation. But that is something which we need to kind of reiterate at each and every visit, that this is not the end. This is something which we are using as a bridge, and what child needs is actually a kidney transplantation. So we are not going to dwell on the record keeping, as it's same as in adults. So now our patient, who is weighs 12.8 kg, and has a body surface area of 0.58. Is found to have blood pressure of 130/84 and now does not have any residual renal function. She underwent CAPD catheter insertion by open method with partial omentectomy along with gastrostomy tube insertion. HD was continued through right TEM catheter for 2 weeks and catheter was flushed after a week of insertion. Low volume well was initiated from post-op day 20 and parents were trained for a week in hospital. So this I have kept, this was a real case and this is just to kind of highlight how the CAPD catheter insertion and post-procedure things should go about. So 1.5% dianyl was the PD fluid which was used, and this is just to highlight, as Dr. Pankaj was mentioning, in a low resource countries, the child is required to be hooked because the dwell volume which we need to use is 700 to 800, and unlike adults who instill up to 2 liters and they can just disconnect once the fluid is instilled inside. So while the parents don't usually prefer to discard the remaining fluid, so the child usually remains attached to the bag. So we have to kind of tailor the dwell volume according so that there is minimal wastage. So that's why the dwell volume was kept in this way. And this child was kept on 4-hourly cycle of with total 6 exchanges, on which she was getting a UF of 600 to 700 mils per day. And she was also receiving amlodipine and atenolol for her blood pressure control. She was brought 3 months later with complaints of increasing cough since 3 days, and parents reported that she is not able to have a good night's sleep. And there was no relief with over-the-counter cough syrup or fever. And now her dry weight we had considered was around 12.8 kg. When she came after 3 months, it was 13.8 kg. And blood pressure was 124/86. There was pedal edema. On inquiry, mother said that she's compliant with the antihypertensive and whatever CAPD prescription we have advised. So now it looks like with having edema and having cough and not able to sleep, probably this child was having fluid overload. Regarding blood pressure, I would just want to ask Dr. Madhura, do you think 124/86 for this child is really hypertension?
So it is definitely hypertension for this child, because we usually follow the 2017 American Academy of Pediatric charts for blood pressure in children. So usually they take into consideration the age, the height of the child and the gender. So if we see on the chart, she is following the blood pressure is more than 95 plus 12 centile. So she is hypertensive.
Yeah, so this is to highlight that sometimes even blood pressure of 110/70 can be just ignored as a normal blood pressure in children. So it is very important to refer to the percentile chart to diagnose hypertension correctly. So we go about looking at the gender, the age and the height, and we have this 95th and 95th plus 12 centiles. For this girl, the blood pressure was 124/86, which was way above the 95th plus 12 centile, which was 119/75. So, Dr. Madhura, I would like to ask Dr. Matnani now, what are the possibilities now? This child has fluid overload, and how should we proceed with further assessment?
So this shows that there is poor compliance of the patient to, as it's written, salt and water restriction. At 4 years, you can imagine the child wants to snack. But a very important thing, we have to stick to salt and water restriction. We have to look at the residual renal function. In this patient, we know she was on tacrolimus FSGS malignant, no urine, so this patient doesn't apply. And there are a few other things. I also have been fooled. I am guilty of that. I've missed a 2D echo patient, because if you have a patient with dilated cardiomyopathy or a hypertensive heart disease having a LVH, the ultrafiltrates will be very poor. Concurrent anemia, which will make the blood more dilute, and in one way it will decrease the ultrafiltration. And very important, all these patients lose albumin on PD. So they have a very low albumin levels, which also decrease your intravascular sort of oncotic pressure, and therefore your hydrostatic pressure in one way is affected to get poor UF. So all these things need to be done. So a 2D echo, do a hemoglobin estimation, do a serum albumin. And yes, again we are going check PD diary. One more thing I want to add here, just for the knowledge of you all, that there's a concept of something called LBF, last bag fill. We'll be coming to the pain, how to go about the pain thing, but I thought I'll introduce this because it's not mentioned anyway. So in children, we don't put at least I don't put the peritoneum dry. So if you have a 2-liter bag, 600, 600, and 600, 1800 total, and last 200 ml we just put that in the peritoneum. So the peritoneum doesn't remain dry, because a dry peritoneum can cause very pain and it has more complications. Good to do a last bag fill, and then when the patient starts, the caretaker starts the dialysis, we have something called ID. They do the initial drain and see how much is coming out. So that I thought I'll just cover that as well.
So this was the diary which this child had according to, so she was on 4 hourly cycles and around 6 cycles, and the dwell volume which we had kept of 700, 700 and 600, that is to avoid the wastage of the fluid. I would like to ask Dr. Madhura that we can see what information is this diary giving us, and what are the strategies which we can use to deal with the issue which is being presented to us here.
So this is how the data is tabulated in the PD diary. So we can see that the balance which we are getting per day, that is the extra negative which we are getting, ultrafiltrate, that is staying at around 350 to 500. And the blood pressure column is showing very high blood pressures, and the weight gain is also steady, that is from 12.7, and she's come to us now with 1 kg weight gain. So definitely this strategy is not helping, that the 1.5% 4 hourly cycles are not helping. If we do by 1100 ml per meter square, the dwell volume of 700 is okay. So what are the other strategies is that instead of 1.5, we can use one bag maybe of 2.5%. In this case, we'll have to use completely 2.5% bag. Then if you want to increase the dwell time, maybe icodextrin can be one option, and APD will be a better option, so get better ultrafiltrate. And in the end, it all boils down that there should be salt and fluid restriction.
Thank you, Dr. Madhura. So I would like to ask Dr. Matnani about using 2.5% PD fluid.
Okay, so I think we're just discussing that it's best to avoid stronger bags. Obviously, for an acute, if the child comes with severe pulmonary edema and is in the ICU, give it for a couple of weeks, but just go back to 1.5%, because at least in my experience, a lot of peripheral patients who come, they are on prescription chronically of 2.5%, and sorry to say, the people there haven't even used 1.5% and tried. It's just going on. So for a long term, this 2.5% is bad for the peritoneal membrane. It will cause a lot of enclosing, sclerosing, capsular, whatever that word is, and peritoneal, and all those things. So anyway, it makes you can see the lot of sugar on that membrane will really make it a lot of fibrosis, and the membrane just won't work when you want it to work. So therefore, it's important not to use stronger bags, and I think Jyoti also will share, we are able to manage on 1.5% absolutely well. I have all the patients, only one ikka dukka is on 2.5, one bag. And we have used for patients who are able to afford, we can use icodextrin. That's the best we have, because one bag can do your job, at least in pediatrics, and overnight or maybe day dwell, whatever, depending on the age. And I'm speaking more about 10 years patients. So there we can aram se do the 2-liter, 5-liter bag, we can use the icodextrin. Okay.
One more practical thing which we have come across is, if the child comes in, let's say, acute fluid overload, of course we can shift to hourly cycles for a day or two to get rid of the whatever fluid overload has occurred, and also look at the reasons for because of which the fluid overload have occurred, whether the compliance, checking the compliance with the fluid and salt restriction before we kind of shift to we shift the modality altogether. And many a times it is practically we have seen, I'm not sure about, I would like to ask you how much the constipation attributes to the decreased ultrafiltration, if Dr. Pankaj can take this, have any experience.
Yeah, you can do it.
Puneet?
So this is the constipation leads to catheter dysfunction, and that can lead to like successively. There's no problem with the infant, but when the drain time are shorter, because the catheter somewhat abuts the sacrum or the coccyx, and that causes sometimes pain and also poor UF. Secondly, to less drain compared to the fill.
Right. So that is what I want to highlight, that rather than altogether shifting to a higher strength of the fluid or different modality. First try to kind of find out the causes, and during that time we can shift to hourly cycles to get rid of the fluid overload, and then slowly shift back to the original cycles and see in-house, in the hospital, how much the child is producing the UF, and then take a decision whether we need to shift to the higher strength of the bag or the shifting the modality. This is a second case, a 7-year-old girl. So she has Arnold Chiari 2 malformation with lipomeningomyelocele with neurogenic bladder and bilateral reflux. So she was CKD stage 3 while she was following up, when she had multiple episodes of urinary tract infection, when she was initiated on clean intermittent catheterization and daily bowel wash. She progressed to end-stage kidney disease by 7 years of age, when her weight was 13.5 kilograms and height was 94 centimeter. So now this poses a different kind of problem. So I would like to ask Dr. Matnani, in this patient, what modality of KRT would you have advised?
So actually, clean intermittent catheterization should have delayed the progression, but despite doing that, we get patients who really go into ESRD, and reflux nephropathy is the cause of end stage. So these patients are tubular interstitial disease, not glomerular. So they have very preserved urine output, and they are NORF, non-oliguric renal failures. So they really have a good urine output, though the residual, the GFR would be poor, but they produce a lot of urine still. So I would really say to preserve that whatever little bit urine they have, I would rather go, though this child is almost 7 years, I would again first go for CAPD to preserve the residual renal function, and a gastrostomy as well, ideally.
So she underwent a CAPD catheter and gastrostomy insertion. She's our patient, following 2 sessions of hemodialysis. Still, she kept having recurrent episodes of peritonitis and urinary tract infection, to the point that she needed change of her CAPD catheter twice. So though we do say that CAPD is a modality of choice, in some scenarios like this child, the mother had to do CIC, the mother had to do bowel wash, the mother had to feed the child through gastrostomy, and she was the one who had to do CAPD as well. So there's a terminology called caregiver fatigue. So as I mentioned, the one person is kind of given the responsibility, though that's why we keep on stressing that whenever we are training, 2 persons at least should be trained, so that the fatigue does not come to one caretaker. But eventually the father is working and mother is the only one who is at home. So there are steps which might get missed. There are steps of aseptic precautions which might get affected. So these are the points which needs to be taken into consideration when we are dealing with this patient. Of course, there is no right or wrong answer for this, but I just thought that these are the scenarios which usually we face as a pediatric nephrologist. I would like to ask Dr. Pankaj, what is the nutritional advice in these children that we should give? Though you have covered some of it during your talks, but just to revise.
So energy, child should get optimum recommended or suggested dietary intake for optimum energy. So it is somewhere around 100 kilocalories per kg. But here child is receiving lot of calories from peritoneal dialysis also. So that should be also taken into consideration and should be monitored for sugar. Definitely salt restriction is warranted. As we discussed, actually it is very difficult, impractical to follow this, because most of them are craving for the things which we don't advise. Limited is for older child, more than 2 years, it should be less than 1.5 gram. The best way is to avoid outside food, avoid all junk food, and whatever is cooked at home that can be under mother's eyes is better, so that she can control the salt intake. Otherwise, it's difficult to control sodium intake of the kid. Now, protein, definitely when child is on peritoneal dialysis, he is losing lot of protein with peritoneal dialysis. So, he requires more amount of protein as compared to his daily requirement. So, for 6 months, which we recommend 1.5 gram per kg, with CAPD it will go up to 1.8 gram. So, with every age, the protein intake has to be increased with CAPD. For administrating such huge amount of protein or even calories, it really becomes difficult for an anorexic child with abdominal wall, peritoneal wall always filled with fluid. So as initially we have discussed, and again we discussing same thing, that it is better we start gastrostomy at early age, because if child is deprived of protein, his not only physical growth, neurological growth will be also hampered.
Thank you, Dr. Pankaj. So this is the point to stress, that many a times parents come across various social medias where they it is actually meant for adults that proteins should be restricted, and that is what then they come, we have read somewhere that proteins should be restricted, but you are not restricting that in our kids. So it is very important to stress on the point that in children age group, their growth is more important than restricting the proteins. And in fact, as Dr. Pankaj pointed out, since there are some amount of protein loss through dialysis, that should be taken into account and added to the daily requirement of the protein in these children.
I have something.
Yeah, sure.
One practical advice that I got from a patient when I asked कि घर पे बना हुआ खाना खाना है, so she said हाँ हम घर पे बना हुआ खाना खा रहे हैं. The child was having a packet of Maggi every day. So any packaged food, something that is cooked in the house with raw materials and not like packaged food. So this took me a while, almost a week, to get to the bottom of it. But then I realized कि घर पे बना हुआ Maggi we get from outside, but it's cooked at home. So
many a times we come across children who complain that they are having pain while doing CAPD cycles. So Dr. Puneet, what are the causes which we should look for when we get children complaining of pain during PD cycles?
yeah, the causes of pain during PD in children is almost the same as adults. The one pain at the initiation of PD, which they describe as tugging or sucking sensation, is the drain pain, which they eventually get adjusted to as the fill volumes go high, and the other is to have a last fill so that the catheter floats and does not abut any of the either the peritoneum or the posterior wall. But dialysate, if you infuse the dialysate too rapidly, or the temperature is at extreme, either cold or hot, then if you're using the one with the lactate as the acidic pH, that can also irritate the peritoneum and cause pain. Catheter malposition, as I said, is another important thing. Constipation is one of the prime factors. Too rapid inflow and outflow again during the APD, and obviously peritonitis or exit site infection and constipation. This is again a very important cause which should not be missed. As I said during the flush before fill, if you have any air bubbles in your circuit which are going into the peritoneal cavity, they tend to sit under the diaphragm and would irritate your phrenic nerve and cause a shoulder pain rather than pain in abdomen. So that is something that needs to be picked up. And the increase in fill volume should be gradual and not as it was shown in the chart, that every very small increments in fill volume, so that the peritoneal fluid and the abdominal wall can accommodate all that thing, and there is no stretch pain that is caused.
So can you quickly cover the different measures according to the...
So peritonitis, there are guidelines by the ISPD how to manage it, and even the exit site antibiotics. You can see the Indian jugaad on the right side, cold temperature, warm the dialyzer with a bag which you use for heating pad. Catheter malposition, get an abdominal X-ray. After ruling out constipation and treating constipation, get an X-ray done to see there's a tip of the catheter lying. And if there is refractory pain, then check the interperitoneal pressure with a manometer and see if it's very high. Then there are other things that can be done, as add sodium bicarbonate or to the dialysate and some topical anesthetic. And last option is to shift to HT if the pain is still unbearable after you've done everything.
Thank you, Dr. Puneet. So I have been indicated by Vipul that I should wrap this up fast. So I won't cover the possibilities of cloudy effluent because this will be almost same as in adults. And so again, this is just fluid overload, and UF failure, this is also same as what we see in adults, ruling out the intraluminal, extraluminal and membrane failure causes. So I would like to ask Dr. Pankaj, what are the indications in which case we should consider removing the PD catheter in these children?
And probably it is the same what we see, and the most important is again infection. So whether it's a refractory bacterial infection, fungal infection, relapsing peritonitis, or intra-abdominal pathology or abscesses which is not getting corrected by intraperitoneal or IV injectables. So the most common indication will be the infection, and second, if it is a malposition which is not getting corrected by other measures. So probably these will be indication to remove PD catheter.
Thank you. So, just to summarize, the goals of peritoneal dialysis is always a bridge. It should be a bridge to kidney transplantation and not should be the sole modality. We should aim at preserving the peritoneal membrane. It should allow growth of a child and his or her normal activity and school attendance. And we should aim to see that the infection is prevented while the child is on peritoneal dialysis. Note about CAPD in India, so we have a huge cost constraint and very few states have scheme for reimbursement for children on CAPD, so that entails a huge amount of financial burden on the parents. And so what we do actually is not a continuous ambulatory but a partial ambulatory, because the child remains attached to the bag for a longer time, so he's not actually ambulatory completely. And the limitation is we have only 2 liters bag available. We have been behind Baxter people to get 1 liter bag, which is actually available abroad, to get it available in India as well. So that is the last point which I would like to mention. Thank you all. I thank all the panelists.
Thank you, Jyoti, and thank you, panelists. My one more aim of stopping you early was, I had 3 questions. One was about gastrostomy and versus jejunostomy. Which one should be preferred?
You're asking for nutrition.
Yes.
So it's basically gastrostomy is for nutrition. We usually don't do jejunostomies in children.
Yeah.
I would rather go for gastrostomy only. Yeah. That's less complications with gastrostomy. Jejunostomy is more difficult to do as well, and it is directly more in touch with the PD fluid, the jejunum. All the ileal loops are more there, and the stomach is more on the upper way, so it doesn't really directly cause any peritoneal complaint. I would rather. We haven't got, at least that's what I know. Jejunostomies we never do in pediatrics for. We never do it. Yeah, we never do it. Yeah.
Second question that I had was, when do we remove CAPD cannula after transplantation? At the time of transplantation, or maybe 2 or 3 weeks later?
Okay. So yeah, whatever we do, we don't remove the CAPD catheters during transplant, because we don't know what is the future output. Because now, in my 10 to 15 transplants I've done, 4 were ABMRs. So it is good that we don't remove them. And once the child has been set on, the kidney function has come to a stable like 0.3, 0.4 in our pediatric age group. Usually by 1 or 2 months we know, and then there's a DJ stent removal time which comes, which is around 6 to 8 weeks, around 2 months post-transplant. So that's the time when we tell our surgeons. But one thing I need to tell you all, that the urologist and the transplant surgeon, they say, "Kisne dala tha wo CAPD catheter?" So obviously it's the pediatric surgeon who puts. So they call the pediatric surgeon. They're all friends in Pune, no worries. So they go and remove it. But in case if they don't, they just call. It's a friendly call. They're one phone call away. And like Shashank is the one who used to put, Shashank Shrotriya, pediatric surgeon. So you just call him. But the urologists, they are very resistant to remove. But I'm very happy, fortunate, our transplant surgeon, who's an adult urologist, a famous one, I don't want to name him, but he usually removes that during the DJ stent removal. So we better don't remove it at the time of transplant, because you don't know what's the future of that kidney in case if things go wrong. Yeah, later.
Any question from the audience?
I have a lay person. The voice is very loud.
You're audible, don't worry. Rohini is always audible.
So, since children are very fussy about eating, how much would the insertion, how much would a CAPD itself be responsible for an inappetence?
It is actually because we are giving dextrose, so that in turn kind of suppress the appetite in itself. So that is what one more reason for encouraging gastrostomy to the parents, that the dextrose which we are using will decrease the appetite. Secondly, the PD fluid, it kind of gives the stomach fullness feeling.
Yes.
So again, they don't feel like eating.
Yeah.
So that's why we kind of encourage gastrostomy, because eventually, inevitably, these children, once the CAPD is put, they don't tend to eat.
And are we doing regular gastrostomies with our
counseling
patients?
them, and we have done in 3 patients.
Okay.
But I would say once you start CAPD or uremia starts coming down, their appetite starts improving. So they do start eating, but all these mechanical problems are a hindrance. But gastrostomies, unfortunately, we are still not successful
Again, it's
in
a
putting in all.
financial burden.
Yeah, it's a big thing.
So it adds to the cost. So
tubes need to be changed when
Yes.
the side goes.
Right,
You have to upsize it every time the side goes.
Right.
There is a leak and infection around that.
But
okay.
then once the track is formed, changing the Mickey button, it's not
Is
that
exact.
difficult as it's just about the track
In terms of the
formation.
cost,
Yeah, in terms of the cost, yeah. But procedure-wise, it's not difficult to change it.
Thank you.
Thank you.
Thank you, Jyoti.